Okay, so this will be part 13 of passing your Checkride in a Robinson R44. And the next section that we're going to cover, it happens to be aeromedical factors. First of which is hypoxia. So it's going to ask you, what are the symptoms of these different aeromedical situations, and what do you want to do about it? So, what kind of symptoms are you going to have, and what are you going to do to fix it, right? So hypoxia is the first one, and hypoxia just means a lack of oxygen or insufficient amount of oxygen. Hypoxia occurs as you go up in altitude. So the air is 21% oxygen, and as you go up in altitude, it's still 21% oxygen. It's just that the barometric pressure is lower, and so the transfer of oxygen is actually much less as we go up in altitude. Right? So now, when would hypoxia occur sooner rather than later? Well, if you were anemic, or if you had any degree of lung disease, you can become hypoxic quicker. Right? Or if you smoke cigarettes, then the carbon monoxide that's within cigarette smoke binds part of the hemoglobin, and hypoxia can actually occur sooner if you're a cigarette smoker than if you're not. The next topic we're going to talk about is hyperventilation. All right. First thing you want to know, what causes hyperventilation? And in general, you pretty much have scared the shit out of yourself and people will start to hyperventilate. So you did something that frightened you, or something occurred that frightened you and caused you to speed up your rate of breathing. And when you do that, when you increase the respiratory rate, you end up decreasing the amount of CO2 in your bloodstream, and that can cause some problems with blood flow to your brain. In extreme cases, if you were to hyperventilate, it can actually decrease blood flow to your brain. You can actually pass out. And there's one of the things that people were taught in the past, and you never, ever, ever want to do this, is to breathe into a paper bag. Do not ever do that. If you have somebody that you think is hyperventilating, don't have them breathe into a paper bag. Very likely they will pass out if you do that. So, okay, so the cause of hyperventilation is scare the hell out of yourself. Okay, all right. What are we going to do to fix hyperventilation? Well, believe it or not, the FAA, what they want to hear is that for you to either talk out loud or sing. All right. If you talk out loud or sing, you are forcing yourself to slow down your breathing rate, and that should fix the hyperventilatory status, and you won't breathe nearly as fast and blow off your CO2 and pass out. So, believe it or not, the answer to the question is talk out loud or sing. If you're in the aircraft with me, you can just talk out loud. You don't have to sing. So, all right, the next subject we're going to talk about is ear problems and sinus problems. And so if you have a viral infection, or if you have problems with allergies, what happens is the eustachian tube that goes from the back, basically the back of your throat, goes over to your inside of your ear and equalizes the pressure behind your eardrum. That can become inflamed, and so that it doesn't work very well. It becomes quite inflamed, and it's hard for it to allow air to equalize behind the eardrum. And so then as you go up in altitude, what happens is the air typically will go out, it will percolate out from behind your eardrum, but then when you come back down on descent, you have a much lower pressure behind the eardrum, and as you descend, it can cause traction on the eardrum, and can be, just lancinating pain. It can be very, very painful. All right? Same thing with your sinuses. When you have a sinus infection, or your sinuses are inflamed due to allergies, as you climb up in altitude, the air can percolate out of the sinuses seemingly just fine. But when you descend back down, you can again have just lancinating pain. You can have severe pain across the frontal sinuses or the maxillary sinuses. You can literally feel like somebody's stabbing you in the forehead with a knife. So if you have any significant degree of eustachian tube dysfunction, where your ears are stopped up, or you have a sinus infection, you're really best to have that treated before you fly. Even at the altitudes that we fly at in helicopters, even going up just a couple thousand feet can cause significant problems. So those really need to be treated. The use of decongestants can help. It doesn't really eliminate the risk of having a sinus block or ear block develop. And inhaled nasal steroids is kind of one of the treatments for it. So, but you really need to see a doctor. If you have significant problems with ear block or sinus infection, you, need to see a doctor, and that needs to be treated prior to flying. All right, next subject is going to be spatial disorientation. And for spatial disorientation, if they ask you any permutation of a question having to do with spatial disorientation, the answer is trust your instruments, all right? Get on the instruments and believe your instruments, all right? So that's an easy one to answer, all right? Now, let's talk a little bit more about spatial disorientation. Spatial disorientation is much more frequent, and you guys may not have been told this or taught this, but you know, there's some areas where west of where we live here that are out to the west that are about 95% wooded areas. There's nearly no ground lights at all. And you know, on a night where you may have clouds and the ceiling may be limited to just 1,500 feet or so, you can't really get way up in the air to try to pick off lights off in the distance. And if your visibility, it may be legal, maybe more than 3 miles visibility, but if it's 6 miles in between lights, it's difficult to see something. So it doesn't have really to do with your test, but I'm just telling you, if you're out and it's a cloudy night and you've got limited ceilings, 1,500 foot, 2,000, whatever, and you know the section that you're going to be flying over is heavily wooded with nearly no ground lights, then you want to really think about not doing that trip unless you've got instruments on board the aircraft like an artificial horizon, a DG, to give you some reference to fly with, because you can become spatially disoriented quickly if you can't see the ground. If you can't see lights on the ground, you're limited by you can't really go up in altitude. It's really setting you up for a recipe for disaster. So again, if you're asked questions about spatial disorientation, and they'll give you some sort of scenario, you're flying at night, it's a cloudy night, and there's no stars or moon to look at, you're over a heavily wooded area, there's no ground reference lights really to speak of, you're essentially IFR. All right, so the question, or the answer to the question is trust your, and they're going to say, what do you want to do in that position? Well, the smart play would be not to go on the trip in the first place. All right, but if you're asked that question, the pat answer for the FAA wants to hear is trust your instruments. But to be very honest with you, not doing the trip in the first place may be the more intelligent the way to approach it. But if you're asked about spatial disorientation, trust your instruments. Okay, next thing we're going to talk about is motion sickness. Motion sickness, here's a rhetorical question for you. Probably not going to get this one on the test, but here's a rhetorical question. If you're in a R44 and R22 and your passenger decides to throw up, how do you keep from being thrown up on? And the answer is, you probably don't. You're going to get thrown up on, all right? So you don't really want your passengers to be motion sick, right? So what's the treatment of choice for motion sickness? And the answer is get them back on the ground. Good old terra firma, get them back on the ground. Now, while you're getting them back on the ground, there's a few things that you want to be aware of. The first thing you want to do is tell the passenger, if they say, oh man, my stomach's down, I feel like I'm going to get sick, is have them look out the front of the aircraft as far as they can, all the way out to the horizon, all right? You don't want them looking out the side window and seeing the world whizzing by like that, because they will definitely throw up all over you, all right? So get them to look out the front of the aircraft as far as you can, out to the horizon. Now, if you're having to turn around to go back to the airport to get them back onto the ground, do so with very gentle turns, just 5 degrees a turn. 5 degrees, you can make a turn. It may take you a couple minutes to get it on around there, but you want to make a gentle turn. You don't want to roll into a 60-degree bank and pull in about 2.5 G's. You're going to throw up all over you if you do. So you want to fly sort of like your grandmother would fly, all right? So 5 degrees of bank, turn it around, and try to be very gentle and get them back on the ground as quickly as you can. So that's the treatment of choice for motion sickness, is get them back on the ground, and no excessive banking or turning if you can help it. Okay, the next subject we're going to talk about is carbon monoxide poisoning. Right? Carbon monoxide poisoning, and I think if you've watched some of the early videos, we talked about where the source of carbon monoxide comes from. It's usually from the engine via the heating system within the aircraft. So if you think you developing carbon monoxide poisoning, what you want to do is turn the heat off, open all of the vents on the aircraft, and then try to get the aircraft back on the ground in a reasonable amount of time and get out of it. one of the things that's not mentioned, if you're on a medical helicopter or if you're on an airplane and you have the ability to put oxygen on, put oxygen on. All right, you guys probably never heard that before, but it's the treatment. It's what we do for patients when they come into the emergency. I'm actually an emergency room physician. It's what we do for patients when they come into the emergency department. If there's any question about carbon monoxide poisoning, we quickly get a blood gas to look at the carboxyhemoglobin levels, and we put them on high flow, high concentrations of oxygen. So if you're flying in airplane, helicopter, whatever, and you think that you have been exposed to significant levels of carbon monoxide, turn the heater off, open the vents up, and if you have supplemental oxygen available to you, put it on. All right. Okay, so what's the most frequent symptoms that you see with carbon monoxide poisoning? And the two most frequent symptoms that I see in the emergency department are headache and lethargy, or good old sleepiness. They come in, they feel like they're half asleep, and they usually have a heck of a headache. All right. So again, if you have access to oxygen, put it on. At the very least, you want to shut off the heat, open the vents, and get out of the aircraft in a pretty short order. Now the good thing about it is most modern day aircraft come equipped with carbon monoxide detectors. So you will likely get a hint, if you get an alarm for the carbon monoxide to go off, believe the alarm. All right, this can get you in trouble if you ignore the carbon monoxide detector. And I should have mentioned it when we were talking about hypoxia, but let's talk about oxygen use requirements in aircraft. So for general aviation, part 91, then if you're the pilot and you're above an altitude of 12,500, between 12,500 and 14,000 feet for longer than 30 minutes, that portion of the flight that you're above, within that altitude for more than 30 minutes, the pilot has to have oxygen on. Once you hit 14,000 feet, the pilot must wear oxygen at all times. And at 15,000 feet, then you must provide oxygen to all of the passengers as well. Now, what a lot of people don't realize, and I said when I did these tapes, I'd mentioned the differences between commercial versus private. And if you're on a Part 135, so I just mentioned 91, between 12.5 and 14, pilot has to use oxygen for that portion more than 30 minutes. 14,000 foot, pilot's got to have it on all the time. 15,000 foot, it's got to be available to the passengers, or provided to the passengers. If you're on a Part 135 in a non-pressurized aircraft, then that actually occurs at 10,000 feet. So between 10,000 and 12,000 feet, for that portion of the flight more than 30 minutes, the pilot would have to wear oxygen. And so there is a difference between the two. But for today, for this test, you need to realize that between 12.5 and 14,000 is where, and for more than 30 minutes, you got to have oxygen on if you're the pilot. 14,000 oxygen on at all times, and at 15,000 has to be provided to the passengers. So realistically, how often is a general aviation helicopter pilot going to be above 12,500 feet for more than 30 minutes and require oxygen? It's going to be pretty darn unusual, actually. Now, I set several world records. I actually have about 23 world records in aviation. They were all set in helicopters and gyroplanes, and I did some high altitude records, and so I had to have oxygen on for all of those. But it's pretty unusual for a general aviation helicopter pilot to get up above 12,500 feet. It just doesn't happen very often. But you still have to know what the requirements are for having oxygen on in the aircraft. And the next subject, stress and fatigue. Those are pretty self-explanatory. They may ask you a question, what's one of the most common symptoms that you're going to see if you're fatigued, and the answer is yawning. So if you see the guy is yawning a whole bunch, he's probably fatigued or daytime somnolence and that sort of thing. He may have sleep apnea or just be fatigued. So that's about the few questions you're going to have to field on that one. I'm actually going to do another video on an accident that happened. This was with a EMS helicopter accident that happened where the pilot actually fell asleep while he was flying the aircraft, and unfortunately all three crew members perished. And with that accident. And just to show you how small the helicopter world really is, my business partner, when he worked for Air Methods, used to maintain that aircraft. And so again, I'll do another video on that, but it's kind of very unfortunate. So. And dehydration, likely again, is one of the most preventable situations you can get into. And so a very common question with that is, what's going to be the first symptom that you usually see with dehydration? And the answer is thirst. All right, so if you're thirsty, you're probably to some degree dehydrated. And dehydration can be a problem in that hypoxia can occur sooner if you're dehydrated. Carbon monoxide has more of an effect if you're dehydrated and that sort of thing. So you want to keep your hydration status up pretty well. Next subject is going to be alcohol consumption, and you guys probably are all aware of that. The limit for alcohol is you have to have a blood alcohol of less than, and this is less than, not a blood alcohol of 0.04, but a blood alcohol less than 0.04. All right, and then the old rule of 8 hours bottle to throttle. You can't have drank alcohol within an 8-hour period of flying the aircraft. So good old 8 hours bottle to throttle. And likely they may ask you, although you went flying, I'm sorry, you went out and drank quite a bit. The next morning you feel like hell and you have a hangover, even though your blood alcohol is less than 0.04. Are you still okay to fly? And of course the answer is no. So just because it's legal, if you're hungover and you feel like hell, it's not a good idea to go flying after significant alcohol intake, even if your blood alcohol was less than 0.04. You may be significantly dehydrated. There may be some other problems with it, but the biggest thing you got to remember is 8 hours bottle to throttle, and your alcohol level has to be less than 0.04. All right, next question has to do with scuba diving. And there's a requirement if you go, there's non-decompressive dives where you go scuba diving. You may only be less than 1 atmosphere, 10, 15 feet deep, tooling around, and you get finished and you come back up. That's a non-decompressive dive. If you go deeper than an atmosphere or so, then there's rules that you have to follow. But if you have to decompress on the way up, where you actually ascend part of the way and you have to stay at that depth for several minutes, and then you ascend farther, and that's what's called a decompressive dive. All right, so if you have a decompressive dive where you have to decompress on the way up, it's a 24-hour wait period. All right. If it's a non-decompressive dive, it's a 12-hour wait period. Now, likely you're, maybe or maybe not, you may not be the one that has gone scuba diving to go flying, but your passengers, it's a good rule for your passengers to follow as well. You don't want anybody developing the bends, as one of your passengers. If you were to go up to a fairly significant altitude, and the patient just recently did scuba diving, then they can develop the bends. Oh, by the way, just like carbon monoxide poisoning, if you have oxygen available to you and somebody got on the aircraft and maybe you didn't know that they had recently been scuba diving and they developed the bends, then put them on oxygen. Again, it's a treatment for treating the bends. A common question they're going to ask you about scuba diving is what gas produces the problems with developing the bends with scuba diving, and the answer is nitrogen. All right, and one of the things you may notice, if somebody is sitting upright and they develop the bends, you ascend up in a aircraft, then usually the nitrogen bubbles will actually ascend to the brain and they'll lose consciousness, so they'll be unconscious. If the patient is laying down, like they're scuba diving and they ascend too quickly, but they're in a sort of a horizontal, many times the nitrogen bubbles go to the spinal cord and they develop paralysis, but they don't lose consciousness. But anyway, it's a good rule for not only the pilot to follow, but also the passengers. You don't want people developing the bends on board your aircraft. Okay, so that wraps it up for Aeromedical Factors, and we'll continue this on in part 14. And if you haven't done so, please like and subscribe. Now the next section that we're going to do on part 14 is just going to be rapid fire questions and answers. Questions and answers. Now I'm basically going to go through the entire PTS from start to finish. I'm going to ask a question, give the answer. Ask a question, give the answer. So maybe something you want to check out. It's probably going to be a fairly lengthy video because there's a lot of questions to field. But I'm just going to rapidly answer. Here's the question, here's the answer. Here's the question, here's the answer. So something you might want to take a look at.